health system capacity management and emergency preparedness, and really how the two functions can collaborate to navigate extreme capacity challenges in the healthcare environment, which is something that certainly we're experiencing here in Massachusetts and really is a nationwide problem. This webinar and the information in it is presented by the RDHRS, the Regional Disaster Health Response System in Region 1, in collaboration with the Regional Emerging Special Pathogens Treatment Center, the RESPECT. Both of those programs are funded by ASPR, and we are very grateful for their support. The content in the webinar is presented by the speakers, who I will introduce in just a second, does not reflect the policy or position of any part of the United States government. It is also not meant to be a substitute for any professional medical advice, etc. And we have no financial relationships to disclose today. So with that, I want to do our introduction. So I'm Dave Reisman. For those of you I haven't met, I'm the Vice President of Emergency Preparedness and Business Continuity for Mass General Brigham and the Associate Director of the Center for Disaster Medicine. I'm very pleased to be joined today by Kian Safavi. Kian, if you want to briefly introduce yourself.
Sure. I'm Kian Safavi. I'm a surgical ICU anesthesiologist clinically and Associate Chief Medical Officer at MGB. So glad to be with you.
Thanks, Kian. Our learning objectives for today are listed on the screen. Developing knowledge of the key components of effective capacity management and emergency preparedness programs in hospitals and healthcare systems, how these functions integrate and how to apply them to complex organizations. And second, to illustrate how capacity management and emergency preparedness programs address crisis scenarios using real-world examples at a large integrated healthcare system. So with that, I'm going to hand the floor over to Kian, who's going to lead us through the first section of our content today.
Thanks so much, Dave. So again, glad to be with you all. And on some level, I think this topic is not only about how we respond to acute large events from a capacity lens and working with emergency preparedness teams, but it's also an acknowledgement that our capacity situation on a continuing basis is so severe and significant that a lot of the principles of coordination and proaction and the way we get organized in an emergency event is really the principles we're trying to carry over to day-to-day operations as well, and how we partner together between emergency preparedness and the health system's capacity management services is a continuing evolution and something we've fortunately or unfortunately gained a lot of experience in our system on. And so today the agenda is really to focus on first just providing you some background about capacity management at MGB, and then Dave will share more on emergency preparedness background at MGB. We'll put a fine point on our hospital capacity crisis and just share some of the data behind just where that is in our system. And then I think we'll just kind of take you through a mini journey of where this all started. This collaboration really all started in the COVID pandemic, and how we really use those lessons to carry forward into our enduring infrastructures and our standard day-to-day operations, and how we've molded those differently since that experience. And then we'll talk some of the outcomes and impact of the work, and certainly ongoing and future challenges that we anticipate. So really the point of this slide just is the mission of MGB, and to share that out, but to really focus on the fact that the capacity crisis we're facing is a threat to our core mission of patient care and quality of patient care. And we do a lot of things as obviously a large academic system like many of yours do as well. But the focus at the end of the day, and the common thread through all of it, is the focus on patients. And it is absolutely a concern of ours that due to capacity challenges, the lack of access to acute care for patients with life-threatening conditions, those with really complex medical issues that are not in our system and are at an outside hospital, but we know them and we care for them. Those are the patients we don't want to delay their care. We need to get them into our system. We also need to make sure patients are progressing through their hospitalizations when they're in our health system. And so I I wanted to bring up the mission because I think this whole operating environment we are in is a threat to patients and therefore to our mission. And so other point I want to make here is that a part of our mission is recognizing all of the different types of care we provide in our system, not only in our AMCs, but our communities. And that is, you'll see a major theme of how we've tried to respond to our capacity challenges, leveraging all of us together as opposed to individually and separately. And so I think those are the primary points to bring across with this mission slide. So just in terms of a bit of background, historically, as I alluded to, each of our hospitals in our health system really led their own capacity operations and access centers and functioned completely separately. And we'll put more detail around this, but effectively we were hearing about patient transfer needs. We were hearing about, separately we were managing our own capacity crisis separately without reaching out to each other. And we've been in an evolution of integration in our system for a number of years now, but that is really the crux of how we're seeking to solve this issue in a totally new way over the last several years. I can say in our integration journey, we started as a health system, as many have it, integrating perhaps some of the back office functions, but really have evolved to integrating the clinical care and operations. And I would say the hospital capacity management and access piece and emergency preparedness piece, we're really at the tip of the spear of this sort of clinical service integration aspect. And since we've been working on this for the last few years, now our clinical departments themselves, so the physicians and the providers are also integrating and have integrated. So we now have institutes that go across all of our hospitals, providers practicing across many of our hospitals, and care operations that go across all of them, all with the aim of making it easier for patients to gain access to care and navigate the system. But it is an ongoing journey and certainly one that has pitfalls, and we can share those with you. But the last thing I want to say on this slide is that this journey really was enabled through understanding our operating environment in a shared and common way. And we did that through something called enterprise asset management, which I will talk about in the next slide, and is really the sort of underlying basis with which we understood where are our problems as a system and where do we need to focus some of our solutions. And the capacity and access issue was chief amongst those. And so it was really the springboard to enabling us to manage this differently. So we can move to the next slide. So, enterprise asset management, just to say what that is, it's a data-informed management strategy. The aim is really to create, at the highest level, a sort of shared consciousness and a shared sense of purpose around all of our hospitals and institutions about what is our operating environment and where are the challenges. And so, very concretely, EAM is effectively a single set of dashboards that leaders from across the system have built in various domains, whether in patient access and transfers, inpatient capacity, emergency department capacity, imaging, perioperative spaces, ambulatory, et cetera. And what it enabled us to do is look at the same data with the same definitions, with the same targets across the entire system. And that gave us visibility into not only like how is each hospital in terms of where it's at with certain levels of congestion, use of different assets, et cetera, but it also put a fine point on the opportunities to work more as a system and realize each other's assets to be able to serve our patients better. So I bring this, kind of higher level concept up because it is the underlying basis upon which we recognized several years ago that our hospitals obviously are way oversubscribed, but it also put light on we've got many patients who are not getting access to care and who are waiting really long amounts of time for their care. And we're concerned about their outcomes. And it facilitated really a catalyst to saying, we've got to solve this differently. And we did. And so just again to say concretely, the basis of the AM is that we're looking at the same metrics, same definitions, same performance measurement and accountability system, and that it's really a platform, I should say, for leaders meeting on a regular basis, sharing best practices, looking at data within each other's institutions at their own, and thinking about how we more effectively use our assets.
Thanks, Kian. As Kian alluded to, I've had the opportunity to work. We've had the opportunity to work together for a long time now, both on planning and response initiatives, and then a few times giving talks like this. And really can't say enough about the importance in a health system like ours of the connection between the capacity and emergency preparedness functions. And we'll talk more about that. I want to step back a little bit and talk about emergency preparedness in general and the way we think about it here at Mass General Brigham. And so a lot of this will not be surprising, but I think it's really important to frame the issue. So the world that we live and work in is just increasingly complex, especially for those of us who operate in kind of the healthcare operations and in the emergency preparedness fields. There is certainly at least a perceived higher level of risk for a number of reasons. We have more events and frankly, more reporting of events that previously likely went unreported. And when things happen, we try to do a better job of studying them and of eventually becoming even more data-driven in the way we design our programs and the way we plan our response activities. There's an expectation, and I think there's likely to be more of an expectation in the future, that we are able to justify and show differences in outcomes when significant events happen and reflect on our preparedness and our capabilities. And I think that that sense of demand for accountability is certainly one of the things that needs to drive programs forward and systems like ours in the future. It goes without saying that the mission slide that Kian went over at the beginning for Mass General Brigham is really what this is all about. Our job in emergency preparedness is to make sure that we are constantly monitoring for anything that could affect our ability to execute on that four-part mission statement that Kian covered. And we're operating in a system where public health is incredibly varied in the way that it's handled in different states and in the country. Healthcare is delivered in so many different venues, so many different formats, in person, online. Think about all the different provider types where people go to get their care now and what that means. And then we also have the issue or the complexity of the public versus private system. And so we certainly have public health and government officials who we work with, but most hospitals are private entities, and the way they operate is largely up to them as long as they're operating within regulatory guidelines. And historically, there's not been a tremendous amount of coordination. And so the work that we do is focused on kind of breaking down some of those barriers and trying to make sure that not just for Mass General Brigham, but really for the region and nationwide, we are more prepared as a resilient healthcare system, healthcare ecosystem, if you will, for events that we know are likely to occur. We're doing all this, as Kian mentioned, in what are almost universally really challenged healthcare systems in terms of capacity. We are consistently overwhelmed. It's very hard to get patients into beds, and we really need to think carefully about the way we are using the patient care resources, including beds that we have available to us. And so, at least from our point of view, there are some things that we think about that make preparedness programs effective. And we'll talk in much more details about these, but it really comes down, in my mind, to looking at preparedness in healthcare as another modality that needs to be data-driven. And so in medicine, we talk all the time about outcomes measurement, what works, what doesn't, how are we evaluating ourselves, who are we comparing ourselves to. And historically, it's been very challenging to do that in preparedness in the healthcare world. And I would argue that now and in the future, the ability to really get actionable data out of after action reports from drills, exercising, and events is going to be increasingly important. And it's really important, obviously, to use that information to adjust response plans and procedures in the future. That's what this is all about, is learning from things we've experienced and trying to do a better job. We know that training and exercising is incredibly important. It's also incredibly difficult, both from a financial and time standpoint in healthcare systems that are already overburdened. And so how do we think about the ability to execute on training people in preparedness, having the time to exercise when we're really just trying to make sure we're taking care of all of our patients and respecting our staff, treating our staff in the way that they deserve to be treated, but also carving out time to do these types of things. So one of the key components for our preparedness program has always been integration into operations. And I think, again, it comes back to the mission statement. And so there are a lot of preparedness programs that are, I think, probably too driven based on regulatory requirements. Regulatory requirements are incredibly important, and our programs are certainly designed to meet them. But I would argue that meeting basic regulatory requirements for preparedness does not automatically mean you have a well-prepared healthcare system, especially for a system that is as large and complex as ours. So some of the key aspects when we think specifically about what it means to integrate an emergency preparedness program into the operations of a hospital or healthcare system. It starts at the top. It's really critical to have strong support from the most senior levels of leadership. And I would say at previously Partners Healthcare and now at Mass General Brigham, we've been incredibly fortunate to have that. We have very strong executive sponsorship. People believe this is the right thing to do, and they're willing to make hard decisions, whether they're related to funding or operations, to make sure that we are keeping this part of the enterprise and this program moving. Understanding clinical operations for anybody working in our department, for anybody who's doing preparedness in general. What are people's jobs in the hospital? What do patients need? What do staff need? And how do we make sure that everyone in our department is developing really strong functional relationships with not just leaders from other departments, but from the staff who are doing the work? I think that to do this work and to do it well, we have to have a commitment to always being available and being willing to be called on as a resource to provide subject matter expertise, and sometimes just to help people solve difficult operational problems that, if not solved, have the potential to take us a little bit outside of normal operations and threaten our ability to execute on our mission. And so we try very hard, and we advocate that others in similar situations do the same, to develop the types of relationships so that leaders see this function as one that can be supportive and helpful during challenging times. There's a large number of events that we get involved in here at MGB related to preparedness. And this is similar, I would say, in many programs across the country, but perhaps we're a little bit more involved in the operations of the organization. And that has taken time, in all honesty, to show how we can provide value and how we can serve and help to make sure that the mission is executed on for the betterment of our patients and our staff. And so a lot of this is not surprising. Of course, our plans are designed around, managing mass casualty incidents and high consequence infectious diseases. But in recent years, we've been spending more time on things like information system downtime planning. How do we respond to cyber attacks? What does it mean when we have medication shortages or supply shortages? And how do we put structure around the people and the systems in our organization that are designed to make sure that some of those basic needs for our patients are met? And then, of course, there's all the kind of what I would consider to be additional bread and butter work of preparedness, infrastructure failures that happen on a routine basis, hazardous materials incidents. But the key message here is thinking in broad terms about operational issues and how preparedness can get involved. So bringing this a little closer to home within our system, prior to really the last 5 years, we had strong preparedness programs, but they were based very much individually at our hospitals and non-hospital entities. We were asked, as Keon mentioned, to come in relatively early in the system development at Mass General Brigham to create one of the first enterprise departments, which we did, and we've been in operation for about 4.5 years. What this means is we have one group at Mass General Brigham, the Department of Emergency Preparedness and Continuity, where all of our emergency preparedness activities are housed. And so we still have people based at our hospitals and based at our non-hospital entities, but we are working together in a very structured and coordinated manner that is reflective of the needs of the individual entities, because that's incredibly important, but it also creates a lot of economies of scale and efficiencies to make sure that we are writing plans once and then applying them to different organizations as needed, rather than having 13 different hospitals write their own emergency operations plan, which makes little sense. And the benefits of this, in my mind, in our minds, are pretty substantial. So making sure that we approach problems in a system coordinated way, and that we're doing things the same way, thinking about resources in a more creative manner, and making sure that we're leveraging resources across the system to respond when necessary. Vulnerable populations and equity are a key part of our planning efforts. We learned quite a bit about this during the COVID response, but honestly, this is front and center in any response that we have now, including, I would call out, medication shortages and supply chain shortages. Thinking about how our approach is really attuned to the communities that we serve, and making sure that, frankly, no one is left out. We have recently, within the last few years, invested a lot more time and effort into continuity planning, specifically making sure that the key functions of this business of healthcare within MGB is able to continue regardless of what is happening in the internal or external environment. We spend a lot of time working with partners and stakeholders across the system to ensure that our facilities are as safe and accessible as possible. And there's a lot of effort with both local, regional, and state, federal governments as well, to make sure that we are true partners and working together to enhance preparedness for our communities. And then finally, as I mentioned earlier, really important that we start putting some data and metrics around this work. I think that's going to be increasingly important in the future for reasons that we'll talk about a little bit later in the discussion. So with that, I'm going to hand the floor back to Keon. He's going to take us through some history on the hospital capacity crisis here, how we've responded, and then we'll come back and talk about the intersection of capacity and preparedness again.
Thanks so much, Dave. So just to get a little bit more into detail about our own numbers within our system, most of our hospitals have been operating at 95 to 100% plus of their operational occupancy. And, we make a distinction between operational and licensed occupancy, but effectively operational occupancy is what the beds we have to work with each day. And so I always tend to put this curve out there. It's a stylized graph of what happens to upstream waiting times as across the x-axis, the resource utilization of anything you're looking at, but certainly in this situation, hospital beds goes up and up and up. And it's a really sobering and important graph to understand, because once you get above 85% occupancy, the upstream waiting times can go up exponentially. And so this is really why we're dealing with ED boarding levels and waiting times to the degree we are, because our resources are this constrained. And I think the positive news on this front is that you can come back down this curve with small perturbations in your intervention. So just as quickly as you can go up the curve, you can come down it if you can reduce resource utilization by a few percent. And I think that gives us, the motivation to not feel defeated in this, and to proactively, work through some of the different solutions you'll hear about today. So this slide shares a lot of our ED data. We do about a little over 500,000 ED visits into our system each year. This is essentially fiscal year 25 data. The vast majority of the patients that are in our ED end up as ED boarders. We define an ED boarder as at least 2 hours waiting for an inpatient bed. Around the system, it's that second number at the top. It's about 76% of our ED patients who are getting admitted will become boarders. But when you look at the hospital-specific information below, you'll see that the top two hospitals there are large AMCs. They have rates of ED boarding in advance of 85 to 90%. So that's really an impact. We know that boarding time is associated with adverse events, longer length of stay, delays in care progression, and even mortality. So this is obviously a critical thing for us to focus on. I want to point out that you'll notice on the left-hand side that ED visit volume is obviously high at the two AMCs at the top, but you can see that even in our community hospitals, and I can say, skipping down, Newton Wellesley, NWH, SLM is Salem Hospital, their ED visit volumes are very high as well. And they also experience significant boarding times. So this isn't just a problem of the academic centers. And the last thing I'll just point out is going back to sort of the top, across the top, we look at other impacts of this, left without being seen or walkout rates, meaning a patient was waiting long enough that they walked out without being seen by a provider, is 3%. That's scary because we want to make sure that those patients are assessed and evaluated and make sure they're actually appropriate to not be seen by a provider or to not be seen in the ED with a formal ED visit or admitted to the hospital. So there's a lot of, this is an example of the kind of enterprise asset management data that we're huddling around every day and every week as leaders. I think many of you are well aware of sort of how, at least in Massachusetts, the Department of Public Health defines how we need to be prepared for capacity crises. And so there's a requirement by the state that hospitals in Massachusetts maintain what they call a code help plan when there are no more ED licensed treatment spaces, that there are internal protocols to try to decompress the emergency department on an urgent basis. And we've defined in our system levels above code help that also help us understand, do we need to pull additional levers beyond just what we would pull at code help? And so we'll talk more. Actually, that system has evolved in partnership with emergency preparedness to be even a graded capacity disaster system that's at level above code help. But I think the main point I want to make at the bottom left is just how frequently we're in capacity disaster or code help. And I share this calendar year 22 data just because it was an impetus for building our capacity command center as a system at the time. And those numbers have gotten a little bit worse over time. But MGH was on capacity disaster code help almost 83% of hours in calendar year 2022, and the Brigham 72% of the time. So it just gives you just a sense of how dramatic these issues are. And certainly they've been in the press, and you can see a link to an article in the Boston Globe on the right side. And a real challenge for us is, as I mentioned, ensuring that the most acute patients have access to care in our system. And this really gets back to the hospital transfer operations. And, this is so important because our hospitals and certainly the academic centers are some of the only places in the state and the region where patients can get the kind of acute care that they need for an aortic emergency, a polysystem trauma, et cetera. So this is really fundamental to our mission, to our society and our region. We were declining about 9,272 patients to our AMCs in transfer because of our capacity constraints. This was, over the course of a year. And 28% of all transfer requests into our system were declined due to capacity constraints. And so this kind of information made it really clear to everyone that we needed to operate differently. And at the bottom, just to share how working in silos has an impact, there were 3,000 patient transfer requests in calendar year 22 where they were overlapping between our academic centers, meaning, I'll give an extreme but real example that happened many times, is an aortic emergency. We get a transfer request call, and the referring hospital is calling MGH and the Brigham separately because they have separate access lines. And obviously they're very worried about the patient, so they're calling multiple hospitals at once. We would potentially be each access center pulling the cardiac surgeon out of an OR at each institution to talk through the case, triage it, and determine whether they accept or decline. And then both hospitals were working separately and without knowledge of each other on the same patient. And so just a very inefficient system, redundant, and the critical piece is not looking at where within our system is best set up to care for this patient in this moment, from a capacity lens, from beds, from an OR availability, surgeon availability lens. Also want to share that, we had a lot of work to do on the throughput of the patient. So after they're admitted, how quickly do they get through their hospital stay? And, for a long time in our system, we didn't really look at our data relative to other health systems and peer institutions. And we've really been on a journey and a discipline journey to do that over the last several years. And so this data, these curves are observed to expected length of stay. At the top, the two lines are MGH and Brigham. And then this goes up until, I think, Q4 of 2023. And then you see the median peer AMCs in blue in the middle, and then a sort of best performer NYU at the bottom. And so these are risk standardized, sort of like measures that take into account patient complexity and look at length of stay performance relative to that. And we were well above the median and certainly way above a best performer like NYU. And so a lot of the work we'll talk about not only is on the access side, the patient flow side, it's also to solve the throughput side, because all of these things are integrally linked to one another. And we'll show some impact of the work we've been doing. Another aspect of our enterprise asset management work is that we actually capture within our health system what are the barriers to discharge of patients in every bed across every hospital in the system. This is actually data that the case managers are inputting on patient care at rounds every day, and that roll up into these dashboards and tell us that we have a large number of patients, like many hospitals, that are medically ready for discharge, but awaiting something. And that's something we even capture details on the right side. What are those specific barriers? It's often waiting for a facility bed. It's waiting for an acceptance to that facility, post-acute facility. It's awaiting insurance approval and other things. So we're capturing this data and then using it to fine-tune what our intervention is going to be that will have the greatest impact on throughput. So just to say, where did we start on our journey to try to solve these problems differently and together as a system? It was really catalyzed by COVID. And, we had certainly individually had different experiences across the system on how to respond to emergency events, but we rarely, if ever, were planning together as a system or responding as a system and taking advantage of each other's abilities. And so very few hospitals had actually even tested their surge response plans at the time. And this was the first time that we engaged in an exercise together to respond together to an event. And I think it was really the start of our, the catalyst for us starting to work as a team of teams around the system to address our capacity issues. And just to share some around how that experience initially went, we had an effort internally and across the system to predictively model what would be the capacity demand of COVID on each hospital in our system. So while the modeling team was at MGH, we shared those modeling insights for every hospital in our system and produced those numbers. And then we planned together. So each individual hospital built its surge plan, and they built it towards an extreme scenario, space, staff, and supplies. And then we shared plans across the system to identify what could we learn from each other. And some of the insights that we found were, one, some hospitals weren't leveraging non-licensed space to increase their general care capacity. So, is there an ability for certain spaces to be able to safely accommodate a general care level patient? We also found that general care beds, actual traditional general care beds, those are better set up for acting as surge ICU space and understanding how we can outfit those beds for ICU capability. We also found that recovery areas, PACU, post-procedure recovery areas were being variably utilized in folk surge plans. We had realizations that really there's no way our island hospitals would be able to safely care for some of the more extreme patients, and those needed immediate transfer. And just that transparency and understanding, that's going to be our approach, came through in this exercise. And then we also really were working on how do we share and understand data about ventilator demand. We also looked at CVVH supplies, and how do we share that across the system, at what levels do we get concerned, and then collaborate to share those equipment across the system. So this was the beginning of meeting as a group to solve problems together. And it in the next slide you'll see it wasn't just a static sort of at the beginning coming up with these plans. We started meeting each and every day as a health system, and what we called our daily COVID capacity operations huddle. And this huddle, which went on for about a year and a half, 2 years in the COVID wave, never stopped and hasn't stopped since then. So now it's five and a half years running. So what we did is each and every day, and this is still what we do, is we share out our capacity situation from an ICU standpoint, a med surge standpoint, ED boarding levels. At the time, we were also talking about what are our staffing levels? We talked about the equipment levels and equipment capabilities at each site. And we created a plan for the day to start the day on who needs the most help, who has relative capacity to give. And we worked together to pave ways to share patients in that sort of way to make sure that ultimately patient was getting access to the needed care in the shortest amount of time possible. And so, this was not only about, I think, creating a shared sense of understanding and awareness. It was also about creating a shared sense of purpose, because the more you knew each other at our different hospitals across the system, the more the operators understood each other and our various situations and our capabilities, the more we solved problems together and saw the problem of one institution as really all of our problems to solve. And it built the relationships that after the huddle, we knew who to reach out to and who to work with, on the details. So this was kind of really a fundamental step forward. And it was so important because our hospitals were affected differently in the level of COVID demand. And so we level loaded COVID patients, like I mentioned, from one ED to the inpatient space of another hospital, if there was that capacity. And what we found was that Brigham and Women's Hospital had far fewer COVID ED visits than our MGH hospital, just because of their catchment area. And so that gave an opportunity for us to send patients from the MGH ED direct to the Brigham inpatient space and into the community hospitals as well in the Boston metro area. That level loading concept carries through today, and we do that for all kinds of patients, well in excess of just COVID. I won't spend much time on this, but we not only worked as a system, but I think we learned how to work as a region, and with the help of DPH in Massachusetts and others. But we really built the same kinds of shared understanding, shared consciousness of the capacity situation, not only in our health system, but with other health systems. And when we were in a pinch, I think we all understood who to reach out to in another health system about a particular patient that we're concerned about. If our ECMO circuits were all used up in one hospital, who do you reach out to in other health systems? So really reproducing the same concepts at the regional state level. So as I mentioned, we sort of have transitioned into our ongoing operations using all the same concepts. So we have a daily system-wide capacity huddle. We meet now not weekly, but on a regular basis and a broader regional huddle, really the same aims of shared understanding and awareness and collaboration. And then I'll talk a bit about we built a capacity transfer and access center so that to really solve that problem of the aortic emergency and the separate phone calls and separate processes, that same, we call it the PTAC, the Patient Transfer and Access Center, works not only on system-wide transfer management, but also optimizing with level loading across the system, community to community transfers, AMC to community transfers, AMC to AMC transfers within our system, repatriation, as well as other functions like ambulance transportation that are critical to patient throughput and outflow. We have a presence of that group of case management, our post-acute rehab facilities, all within this center in order to get the patients through their hospital stay. And I think I talked about these concepts. We can probably go to the next slide. So this is our the functions within our patient transfer and access center. I'll start with on the right, upper right side, central access and triage. We have a single MGB nurse triage team that is receiving transfer requests from anywhere, anywhere in Massachusetts, the region, nationally, and even internationally, and is going through one single triage process to determine where within the system to target that request. And we'll talk about the decision, how that decision is made and the factors taken into account. They work hand in hand with and sit next to the bed managers in our system. And so working in tandem to not just figure out who needs to get a bed and how urgent are they, but how do we make them a bed as quickly as possible. Skip over to the left side, the blue, transfer capacity optimization. A lot of those pathways that I mentioned, we used to call them alternative pathways, but they're now standard pathways, which is community to community transfers, AMC to community, and other repatriations, other ways to level load in our system. In the front of the room, and it's kind of like a stadium seating capacity center, large room with all the access nurses and bed managers there. They're looking forward in the room to a very large screen that has the capacity situation in all of our hospitals, community and AMC, in real time updated. And so they have a real time understanding of what is the ED boarding situation? Are we on capacity disaster code help? What is our what's our inpatient occupancy from a med surg and ICU standpoint? At the bottom, you'll see hospital throughput support, that concept that there's critical services that really help with the outflow of the patients, which is just as important to getting patients in. And so we have a system-wide transportation EMS coordination group that is not only working with our own EMS services, but also with our EMS vendor and other EMS services sometimes to be able to facilitate critical transports, especially to avoid discharge delays where a patient stays longer than they need to because they're waiting for an ambulance. And then post-acute care. So we have a liaison who's working with us on all of our post-acute facilities and connecting with those and pulling patients from the inpatient setting into those beds. And lastly, this is the orange part on the right, is emergency incident coordination. This kind of an operation fits really well with responding to an emergency incident as a system rather than individually. And so it's this group in the center that is working with Dave and his team on, how do we make sure that if we get a sudden bolus of demand because of emergency incident, that we're trying to level load that in our system, match patient need with site of care capability, and avoid overwhelming any particular hospital and limiting the amount of time it takes to get the patient in. Just say kind of in our patient transfer and access center at the bottom, there are 4 key triage factors we take into account: capability, choice, continuity, and capacity. So we're trying to maintain the continuity of patients with institutions from which they typically get their care. We're trying to respect choice when a referring family or patient has a very strong choice of a particular hospital. we're obviously trying to match the capability of the hospital with the patient need. It really flips it on its head that we're first trying to ask, are they appropriate for our community hospitals before putting them through to our AMCs? Because we have highly capable community hospitals, and them being able to take some of those patients really helps ensure the AMC has the capacity to take the most acute patients. This is our sort of standard triage approach for any patient, but the couple things I want to call out is one, again, at the top, the first question is, are they community appropriate? The second piece I want to mention is we categorize every patient by their clinical need based on their urgency, and then connect those urgency levels with specific goal turnaround times to getting them into the system. And so we do that work in an organized way and then track our outcomes based on those urgency categories and try to reassess where we need to improve our operations. I think the curves didn't copy perfectly well here, but you see the dots. So I won't go through all the data here, but I think on the upper left, when you look at the total number of requests we get through our Patient Transfer and Access Center each month and then throughout the year, we get about 1,400, 1,500 transfer requests that we actually get into the system. And then there's another proportion, around 500 or so, that we cancel. And that's because we can't get them in for one reason or another. And we spend a lot of time capturing for every case what those reasons are, categorizing them, and then tracking them and trying to improve upon them. And now just to point out that kind of a data, and that's the data that then feeds into our enterprise asset management dashboards and that we meet around and talk about as a system. So just to show you in the middle graph, we're looking at avoidable losses and unavoidable losses. So we identify that some cancellations are really unavoidable. A patient declined transfer, a patient actually got better and didn't need transfer. Then there's avoidable losses. So our inpatient capacity delays, if we're delayed connecting with our providers and things like that. So we're constantly monitoring this. On the upper right, we're also looking at our ability to get patients from outside community hospitals to our community hospitals rather than to the AMCs. And so we do about 50 to 90, 100 of those a month. And then I'll just point out at the bottom left, we're also working on pivoting patients across the academic centers. So when one academic center doesn't look like they have capacity, we pivot them to the other and get them in there. So we do about 50 of those a month. Maybe I'll skip this slide. Just to say, we are tracking our AMC emergency department patients who we then can transfer to our metro community hospitals directly to an inpatient bed. So you'll see we have a lot of inpatient bed requests and admissions out of our AMCs. We screen all of them for eligibility to go to the communities. A certain subset, about a third, consent to that. We get their consent to go to the community hospital. And then a subset of those we're actually able to get there. There are sometimes delays that lead to cancellations in that pathway that we work on. But I just wanted to point out, we do about, you can see over this time period, we completed about 2,500 of these requests in fiscal year 25. And in the left-hand side, in those blue graphs, gray curves, you can see the blue is the waiting times for patients who are going via this pathway to get into a bed. The gray is if you're waiting at the academic center to get into the academic center bed. So we confirm to everyone through data that it's much, much better if you're appropriate to go to the community, that you actually go to that bed. And it's really helpful to share this kind of information with patients because you can get into a bed faster. And we talked about some of the risks of waiting in the ED. I'll just say one liner here is that same length of stay observed to expected data. We have a many-pronged effort in our health system to work on that. You can see the blue solid line is our academic centers and how their O to E has trended since about a little over a year ago. We've made a lot of progress there. We're still not where we want to be. Our goal is to get well into the green. And the dotted line is our median peer academic center. So we want to be able to push down below that. But there's been a lot of progress on that front. And maybe the last thing, we can skip to the next slide. We found that our capacity disaster code help distinctions have been inadequate. There's not enough granularity. We're always on capacity. We're often on capacity disaster. So what we realize is we need to formulate a more detailed tiering system. So we actually have a capacity disaster tier 1, tier 2, tier 3, and tier 4 now that we've built with emergency preparedness. And those are all connected to system-wide operational interventions to help support the hospital in that, or hospitals in those tiers. So we're actually operating system levers, not only in the PTAC, but also in home hospital, in our post-acute care network, in the ambulance realm, and in other places to help support as one system. And actually the tier 4 is where we activate our emergency plans, and actually delineating when we will do that is really important. I think I can sum up sort of this slide to say we're not only working together continually with emergency preparedness and how we respond to day-to-day strained operations, but also recognize that when an event does occur, how do we convene folks around the system in a very timely manner to figure out where are we going to send those patients, coming out of whichever event we're faced with. And so how do we level load patients in the moment? It's a little different than the daily operations. We need kind of decision makers in those events who can go outside sometimes outside of the typical operating expectations of the hospital. And so it's a little bit of a different dynamic than our typical daily huddles, but important to say we built that capacity liaison team as representatives from every hospital in our system who have that level of decision-making ability and also have the insight to make the right decision. I think I covered this in what I said. I know we're pressed for time. So is this, Dave, back to you?
Yeah, absolutely. Thanks, Keon. Thanks so much for all the detail. So I'll move quickly through the last few slides to make time for questions if there are any. But when we think about the outcome of this work that has come from the partnership between capacity management and emergency preparedness, we mentioned a lot of the good things that have happened already, but just a little bit more granularity here. So we did actually include the capacity command liaison position in our incident command system. And so that is to make sure that we have somebody when we activate a response who is focused specifically on capacity, not just for one of our hospitals, but for the entire system. When we think about the types of events that we've responded to over the last several years, this is just a small sample, but this is kind of proof that all the effort has been worth it. So when we think about something like the Brockton Hospital fire that many of you are familiar with, a lot of the kind of normal internal facilities related issues we have that sometimes require patient movement, having access to the capacity leadership team, 24/7, 365 access, having them built into our standard response structures and the way we notify emergently during an event, it's really benefited us, and it's certainly benefited our patients and our providers. And you can see that it's really a wide variety of events, whether we're experiencing a surge in behavioral health patients, whether there's something related to high consequence infectious diseases. The system has really proven to this point to be incredibly valuable. And when we think about why, some of this is pretty simple. Being able to bring the right leaders together to make decisions quickly sounds like it's easy to do, and now it is, but we had to kind of work to get there. Making sure that we have access to real-time data, not just from one or two of our sites, but really from all of our sites, all of our entities, and looking at the enterprise level view of that data has been incredibly important. Working with Keon and the capacity team, we share much more situational awareness than we used to. It's not that we didn't want to share, it's just that we didn't have a pathway to do it. So they get notified pretty early on when there's something happening either internally to our environment or externally that we think could affect capacity in any way. And importantly, this work is really related to a lot of what Keon talked about, which is really identifying what's the right site of care for our patients during normal operations, and during a disaster, what do we need to do to protect our academic medical centers, our tertiary facilities, so that they can take care of the people who really need them, and then we can move other patients to other locations where they will still get great care, but we're reserving the most limited resources for those who need it. And so when we think about this work in the future, I think this is going to require really continued investment and time. And so it's not like this is done, we're checking a box and we're moving on. There will be ongoing monitoring and adjustments as needed related to everything from the capacity tiers in the emergency department that Kian went over, to the way that we staff our emergency response centers, who's involved, and what we need to do to make sure that we're able to respond quickly and be nimble when these events happen. I think that the challenges related to investment and preparedness and the continuity infrastructure is really important to highlight, especially now, given some of just the challenges that healthcare is facing and that are just happening kind of across the nation. And so how do we continue to make this work a priority, and a priority for people who make funding decisions, which really, really impact our ability to do this work? And then thinking about that kind of gray zone between what's normal operations and what's emergency operations. We've worked really hard to define that, and I think the best example is kind of the tier 4 of the emergency department capacity tiering system that Kian went over. That's when we move into emergency operations. And so it took us a little bit of time to get there, but operating in the gray can be really problematic. And so we want to be very clear about that. So with that, I'm going to stop. I will pull these slides down, and we're happy to open it up to questions. I will just check the chat. Okay, I don't see any questions. I don't know if anyone else does. Okay. So with that, I want to thank everybody for coming today. Certainly thank Kian for his expertise and for the ongoing partnership that we're really fortunate to have to do this type of work. This information is all going to be made available to you. These slides will be posted to the website that we showed at the beginning. And certainly if Kian or I can be particularly helpful to anyone, you should always feel free to reach out. We're happy to assist in any way that we can. But mostly, thanks very much for your time, and have a nice weekend. Thank you.